or Jojo or Josephine. And this is us on Halloween dressed as Sesame Street characters. So kind of on to the bulk of the talk. I have to disclose that I am talking about medications that are off-label. But in terms of our learning objectives, I believe these were shared with you prior to the talk here. But I'm going to review the impact of sex steroids on skeletal health. I'm going to discuss some special considerations for bone health in transgender and gender diverse adults. I'll abbreviate that TGD throughout the talk. And then we're going to review the impact of gender affirming hormone therapy, also abbreviated GAHT, on bone. We're going to identify TGD adults who are at risk for fracture and review recommended screening guidelines. And then towards the end of the talk, we'll have some time to look at microarchitectural changes and data here collected in Rochester. So hopefully this is going to work out. I have a poll here. For those of you who have a smartphone, you can take a screenshot of this QR code. And for those of you who don't have access to that, you can use this polleverywhere.com/Jennifer Hewlett 266 to get to the poll here. But the question is, what short-term changes, particularly at 12 months, do we expect to aerial bone density or DEXA scans after initiation of an estrogen-based hormone therapy regimen? So I'll give everybody a few seconds to put their answers in here. Oops, sorry. All right. So great, I have some answers rolling in. I have 57% answered D, that bone density is minimally changed. 29% answered A, that bone density is increased at the lumbar spine. 14% answered B, that bone density is reduced at the lumbar spine, and nobody answered C. So for this question, the correct answer is actually A. 29% of the participants answered, but we'll kind of go through the data and hopefully explain the reasoning behind that. So just to go back a little bit and understand more about sex steroids and bone biology. So we know a fair amount about sex steroids and the skeleton, particularly as it pertains to cisgender adults. But kind of some of the first studies that looked at the role of estrogen in skeletal health were published in the 1940s. And these were kind of pretty intricate studies looking at postmenopausal women and kind of replacing estrogen typically with equine estrogen or synthetic estrogen, and looking at changes in 24-hour urine nitrogen, 24-hour urine phosphorus, because we didn't have DEXA scans back then, serum calcium, etc., and found that estradiol replacement in postmenopausal women generally had positive impact on skeletal health. Then in the 1970s, there were some more randomized control trials in women who had oophorectomy, and it was determined that estrogen replacement therapy leads to preservation of bone absorption in cisgender women after oophorectomy. And then up until that point, it was kind of assumed that estrogen was the dominant sex steroid that impacted skeletal health in women, and then testosterone was the dominant sex steroid that impacted skeletal health in men. But actually in the 1990s, through studies of looking at, sorry, one second here, that estradiol levels were positively correlated with higher bone densities. So it was determined at that point that estradiol is a dominant sex hormone in cisgender men as well. And then in some studies eventually published in 2000, done at Mayo Clinic in Rochester, pretty intricate study design giving GnRH analogs to cisgender men and also giving aromatase inhibitors, so blocking endogenous testosterone and aromatization of testosterone to estradiol, but there is a role of testosterone by itself at preventing bone resorption, even when aromatization is blocked. So, kind of to summarize some effects here, in adults, estradiol has multiple impacts at different levels within the skeleton, but overall, the role is to decrease remodeling, maintain bone formation, and decrease bone resorption. And then for testosterone and skeletal health, a lot of these same mechanisms will still be in place because testosterone will be aromatized to estradiol. But we think testosterone has direct impact via androgen receptors on osteoblasts and osteoclasts as well to increase bone formation and also decrease bone resorption. So when we kind of put this all into context and look at how sex steroids impact bone health in cisgender individuals, kind of looking at cisgender women here, high estradiol states will have positive impact on both cancellous or trabecular bone and cortical bone. And there will also be some impact of low testosterone, particularly on cancellous bone. And then in cisgender men, high testosterone will be impacting cancellous bone, and then a lot of the other skeletal impacts will be from aromatization to estradiol, which will then impact cancellous bone and cortical bone to a greater extent. So we can kind of conclude that estradiol is the dominant sex steroid in both cis men and cis women, really everybody, and testosterone, even without aromatization, has some effect on trabecular bone. So when we kind of take what we've learned in cisgender patients and try to conceptualize what might be happening in our transgender patients, I'm looking at the right side of the screen here in transgender men. Exogenous testosterone will lead to high levels of testosterone in the body that will similarly impact cancellous bone, and that testosterone will still be aromatized to estradiol, which will then impact a little bit cancellous bone, but kind of predominantly cortical bone. And on the other side of the screen here for trans women, there's a high exogenous estradiol, and that will pretty much, once it's titrated to the goals that are outlined in Endocrine Society, which we'll discuss later, that's typically a high exogenous estradiol, which is similar to premenopausal estrogen levels in cisgender women, and a very low testosterone, often suppressed to less than 50 for total testosterone. And that exogenous estradiol will act at cancellous and cortical bone, but probably the testosterone levels are quite low, and that might have a little bit less of an impact on cancellous bone. So in trans men, we expect that the physiology probably is pretty similar to cis men as long as aromatization is intact. And then in trans women, the exogenous estradiol protects cancellous and cortical bone, but the effects of endogenous testosterone are quite muted. So moving on to more specifics about bone health in transgender and gender diverse individuals, there are some considerations that we have that kind of apply to the whole population. So vitamin D deficiency is quite prevalent in trans patients as it is in cis patients everywhere. Some studies are, have, depending on the threshold for the 25 hydroxy vitamin D that's used, is prevalent in 90% of patients. So that's certainly a factor in overall bone health. Some patients will choose to undergo gonadectomy, and so that might impact bone health, especially if that gonadectomy is also associated with lower dose hormone use. So the skeleton might not be seeing as much sex steroids as it would be prior to gonadectomy. Those who've received GnRH agonist use, particularly during puberty, will certainly impact bone health. And then we know that body composition changes happen once an individual starts gender-affirming hormones. And in trans women, lean muscle goes down, and in trans men it increases. So that does change bone health parameters as well. And then minority stress also impacts bone health. And so kind of to talk about that topic a little bit more, it's kind of a little bit self-descriptive in that it's a stress experience by a minority group. but it does have, certain behaviors that people might partake in to alleviate some of that minority stress. So that might be using tobacco, drugs, and alcohol. It might be reducing physical activity. And I'll say also in our trans population, because of some societal factors that might restrict participation in group sports, that's particularly an element that impacts bone health. And then some poor diet choices, perhaps maybe getting less vitamin and minerals from food, can contribute to minority stress, and particularly that would be pertinent to bone health. So when we think about bones at baseline, even prior to starting gender affirming hormones in our trans women population, we know that bone health is actually quite compromised at baseline. So in this study looking at 49 trans women, before even starting estrogen, there's significantly lower bone density by DEXA scan at the spine, total hip, and femoral neck. And I think these numbers are kind of staggering personally, but it's quite low as compared to cisgender men. Even the radius and tibial cortical bone areas were smaller, and there was a significantly lower 25 hydroxy vitamin D. In this cohort, it was 2/3, so 67% of patients had vitamin D deficiency, and there were significantly higher PTH values, and 4 patients actually had frank secondary hyperparathyroidism, where none in the cisgender men control group had hyperparathyroidism. And we see significantly lower body lean mass, grip strength, and muscle mass, and lower weekly sport activity as well. So when individuals are kind of going into their, gender affirming hormone therapy process, the bones are kind of not starting off at a good place. So what is gender affirming hormone therapy for transgender women? Well, it consists of 2 parts or 2 components, typically an estrogen and an anti-androgen. For the estrogen side, we're using oral estradiol, transdermal estradiol, and parenteral estradiol. So these are kind of the typical doses here. And these are kind of written in the Endocrine Society guidelines. But in terms of treatment targets that we're looking to see, we usually are aiming for an estradiol between 100 and 200 picograms per ml, which is kind of the mid-range for cisgender women who are premenopausal. And then also, along with that, estrogen is going to be an anti-androgen. And in the United States, that's most often spironolactone, which is dosed at 100 to 200 milligrams daily. And the goal of that is to suppress testosterone to less than 50, as I kind of alluded to earlier. But a lot of the European studies will actually use cyproterone acetate, which is not FDA approved for use in the United States. So it's not really used here, but a lot of the research studies that we're referencing today were patients on cyproterone acetate. And then also anti-androgens can be GnRH agonists, which in adults might particularly be used if that testosterone cannot be suppressed with estradiol and spironolactone in combination. So what do we know about DEXA scan changes after estrogen-based gender affirming hormone therapy is started? So in a study of 231 trans women, after 1 year of being on gender affirming hormone therapy, lumbar spine bone density increased by almost 4%, and total hip and femoral neck bone density also increased, but the most profound increase was seen at the lumbar spine. And then in a study that followed patients for up to 10 years, and both of these are out of Europe, there was kind of this blip here of increase in lumbar spine bone density at 2 years, which then kind of leveled off at the 10-year mark. So by the time when we compared baseline to 10 years, there was no significant difference in bone density. We do see a change in the Z-score of increasing by 0.22 from baseline to the 10-year follow-up point. What's important to note about the subgroup analysis of the 10-year study is that those who had higher estradiol concentrations had more robust increases in bone density, which I think intuitively makes sense. But the little tertiles that they looked at in this study were those who had kind of a mean estradiol concentration of 120 had more significant changes in bone density. And there was no association with degree of LH or testosterone suppression and correlation with bone density changes. So what do we know about volumetric bone density? Well, there's kind of two main studies that are published looking at this. The first study is in the same 49 women that we reported numbers about their baseline bone health prior to gender-affirming hormone therapy. So when peripheral quantitative CT was done in that group, there was really no change in cortical bone density, but trabecular bone density was reduced as compared to control men here. And that was sustained over the 2-year period of estrogen-based hormone therapy. And then in another study in 2022, this one out of Australia, they studied 40 trans women after 1 year of gender-affirming hormone therapy. And they had different results than what was reported in this study here, but they noticed lower total volumetric bone density, lower cortical bone density. So this one had no change. This study had lower cortical bone density. They also noted higher cortical porosity, which we think is kind of unfavorable to have more porous cortex. And then the other changes here, I've kind of highlighted, they're all pretty unfavorable in terms of the volumetric bone density changes, but they saw a reduced trabecular bone volume fraction, so less trabecular bone in the skeleton, and a lower trabecular number, increased trabecular thickness and separation. So the trabecula are getting lower in number, and to compensate for that, they're getting thicker and separating more. So it's kind of, instead of having multiple small trabeculae, they are getting larger and more separated. So those are generally unfavorable changes in the trabecular bone. Now, switching gears a little bit to talk about what happens with testosterone-based gender-affirming hormone therapy. But this is actually prior to starting testosterone. Actually, bone density is quite similar when compared to cisgender women at baseline. So we don't see the same reductions in areal bone density. We don't see change in bone size. Vitamin D is similar in both groups, and there's a similar lean muscle mass and strength. So quite different than our patients who are interested in estrogen-based hormone therapy. In terms of what encompasses testosterone-based hormone therapy, it's typically testosterone esters. Oftentimes it's given intramuscular or subcutaneous at a weekly frequency. So typically our practice is to start a little bit lower and increase gradually over time to kind of achieve a testosterone in the mid-normal range for cisgender men. And then some patients will also elect for gels. Typically it's androgel, a 1.62%. It's titrated to achieve the same goals. Now, after 1 year of being on testosterone-based gender-affirming hormone therapy, in almost 200 trans men, they also saw increases in bone density. The most profound increase was at the total hip, but at the lumbar spine, the whole cohort experienced almost a 1% increase. But when they looked at those specifically were over 50, there was over a 4% increase. So older patients who start gender-affirming hormones, specifically testosterone, have a more robust increase in their lumbar spine bone density. And then looking at more longitudinal data up to 10 years, in a study of 70 trans men, lumbar spine bone density was similar to baseline. So you can see a similar trend here where bone density kind of increased in the short term and then fell back down at the 10-year mark to non-significant from baseline. And then at the on the Z-score side of things, there was an increase in Z-score of 0.34 when compared to the baseline numbers. And then one correlation that was seen in the 10-year study was that those who had suppressed LH were having more robust increases in their, this is lumbar spine bone density, as compared to those who did not have a suppressed LH. But when they looked at association with estradiol levels and testosterone levels, there was no association with bone density improvements in those sub-analyses. Now, looking at volumetric changes in transmasculine individuals, this is that same study out of Australia, looking at volumetric changes. So, sorry, the color coding on this is a little bit switched around, but we saw the total VBMD was increased. So that's a favorable change here. We saw increased cortical thickness, which is favorable. So these two should be green. And this trabecular thickness was increased as well, but we didn't see any other significant changes in the other trabecular bone parameters. So generally kind of favorable changes happening here. Probably definitely in the cortex with the cortical thickening happening, and then questionable in the trabecular bone space as well. So kind of moving on to, we talked a little about what's happening with bone density, both areal and volumetric bone density, but how does that translate to fracture risk? And how can we identify patients who are higher risk for fracture? Well, there's been really limited studies about fracture risk in the TGD population. This study was out of Europe, but it was quite large. So it studied over 2,000 trans women, and almost half of those were over 50 years old. And then studied about 1,000 transgender men. And when we look at the results here, these are percentage fractures. Concentrating here on the left side of the graph, we see trans women who are less than 50. This dark line here indicates that the fracture risk that was observed was intermediate between the control men, which is the middle bar here, and control women here. But there was no significant difference. When we look at the fracture risk in the trans women over 50, there actually was a significantly increased fracture risk in trans women as compared to control men. But that fracture risk, as you can see, was quite similar to cisgender women. So maybe some expected fracture risk here in the older population. And in trans men, actually, there was a lower risk for fracture as compared to control men and control women. But the significant finding here was that the fracture risk, percentage fracture was lower in the trans men as compared to control men. This is pretty much the only study that's available trying to calculate fracture risk, and it's out of Italy, and it's using this risk score called the DEFRA osteoporosis score, and it's quite a small cohort, so it's 57 individuals, but they did have history of gonadectomy, and 14% of the cohort had this intermediate to high risk for fracture using this adjusted model. So that's depicted here in this kind of yellow curve. There is one patient who had kind of a higher risk for fracture, but on their bone densities, 40% of the cohort had low bone mass for age during this cross-sectional study. And there was a high prevalence of sedentary lifestyle, 56%, kind of a high prevalence of active smokers, 37%, and they had a over 90% vitamin D deficiency, but it was defined as less than 30. So I guess it would be suboptimal vitamin D. And then kind of strikingly, there was a low compliance with gender-affirming hormones in this cohort. So these were all patients who had gonadectomy, and then on top of that, they were not as compliant with their estrogen-based hormones as one would expect. So that might be impacting the risks that we're seeing in this study as well. Important to note, there were no fragility fractures observed during the study, but again, it's a very small cohort here. So ISCD actually does have specific recommendations for gender diverse individuals, and they have been doing that since, I believe it was 2019. But some kind of subgroups within the TGD population that need to be possibly screened earlier for, low bone mass for age or osteoporosis are those who've had a history of gonadectomy, and particularly those who've had gonadectomy and are on low dose hormone replacement or suboptimal hormone replacement. So that kind of also covers this box here. So those who have hypogonadism without plans to use gender affirming hormones are also at risk. And then anyone who's received a GnRH analog during puberty should be screened earlier for bone loss. And then those who have other risk factors for bone loss, such as hyperparathyroidism and smoking, etc. And those who are identified as higher risk should be screened with repeat bone densities every 1 to 2 years, as long as that risk factor still persists. And I think that's pretty much the summary of the ISCD recommendations. And then once you get your bone density, kind of have to think about what to do with the results. So it's a little bit easier if patients are over 50. So just as we would in the cisgender population, we use T-scores if someone's over 50 because the T-score compares everybody to a uniform white female normative database. But for those who are less than 50, we have to think about which Z-score to use and which reference population that will compare our patient's bone density to. So for those who identify as transmasculine or identify as a trans man, you would use the male Z-score reference range. And those who identify as non-binary, you would use a Z-score that corresponds to an individual's sex recorded at birth. You'll note that this will probably change the Z-scores or change how you think about how to interpret the Z-scores. So if you have a trans woman, for example, who is less than 50, she's probably going to have higher Z-scores because the reference population probably has a little bit lower bone density than that trans woman does. So kind of to illustrate this, it's easier if I have an example here, but this is a report from a patient I saw in clinic, a 75-year-old trans woman who came in for follow-up, who has been on estrogen-based hormone therapy for 20 years without interruption, and she had had no gender-affirming surgeries before, but she had this history of low bone density on a prior DEXA scan from 2017. We didn't have the information about that. But if you kind of look here on the right side of the screen, you'll see that our radiology department separated into findings compared to female reference population and findings compared to male reference population. But you'll see the T-score is the same as we would expect it to be because the T-score is going to be the uniform normative database of white women that everyone gets compared to. And then when we look at the Z-scores, we see that when we compare to the female reference population, the Z-scores are more positive than when we compare to the male reference population. So definitely that wasn't necessary as we talked about, but our radiologist kind of went above and beyond for this person's bone density report, which is nice, but not needed ultimately. It's a good example to learn from. So right now we have, a significant amount of knowledge gaps. These are just a few that, you can identify just doing the literature research that we've just gone over. But there's no normative database of transgender or gender diverse individuals for Z-scores. So we're kind of stuck using the normative databases that we have, which isn't ideal because we know that bone health is different even prior to gender affirming hormones. We have data about microarchitecture, but it's pretty conflicting. We don't know much about fracture risk or fracture risk assessment. So more information about that would be helpful, particularly in a US cohort, because a lot of the studies in Europe, as I mentioned, are using different gender affirming hormone regimens, particularly those who study the trans women. They're using different anti-androgens, and there might be different prevalences of smoking and obesity that would impact bone health. And then we have really not many recommendations or guidance for non-binary individuals. So that kind of brings me to talking about the research study that was done here in Rochester looking at cortical and cancellous bone before and after gender affirming hormone therapy. So the purpose of this study was to identify changes in volumetric bone density in adult transgender individuals receiving gender affirming hormones. So a little bit about the study design. It was a prospective observational study, and it was conducted between March 2021 and March 2023. And patients were recruited directly from our transgender and intersex specialty care clinic. So they had one baseline study visit where a whole body DEXA was performed, and also high resolution peripheral quantitative CT was performed at baseline. And then they started gender affirming hormones with their provider. Over the 12 months between study visits, their hormones were titrated per institutional protocol, and individuals started whatever gender affirming hormone regimen worked best for them personally. So there wasn't a standardized approach to hormone management. And then they came back at 12 months for another whole body DEXA scan and another volumetric bone density. So just a brief mention of the patient characteristics. Number one, this was a small study, so we have 5 transfeminine individuals and 4 transmasculine individuals. They're pretty similar in age, but you can see here the BMI differs quite a bit between the groups. Both groups were at least in the overweight category, but in the transmasculine individuals, their average BMI was 37. Calcium was normal at baseline, and looking at the total testosterone, it was within the reference range for their sex assigned at birth at baseline. And then looking at the estradiol prescribed, most of it was oral estradiol, but there was one individual who decided to do injections and one who decided to do topical treatment. And then testosterone, it was mostly injections and one topical. So when we look at our data, at least on bone density changes, we saw that similar to the studies we talked about earlier, there was a 5% increase in bone density, which was significant at the lumbar spine, and there was also a 2.4% increase at the distal radius. We did also look at the hip, and there was increases in bone density at the femoral neck and the total hip, but those were not significant, so I did not show them here. And then when we look at the quantitative CT changes, I've similarly highlighted things into favorable being green and unfavorable being this kind of orangish red color. We can see here that cortical porosity decreased. So the cortex was getting more condensed and less porous, which is a positive change. And cortical thickness was increasing, as was cortical area. So cortical bone was positively impacted by estradiol. And then we see here on the trabecular side of things, we see similar findings to that Australian study that we talked about, this Brotherton et al., that we see kind of unfavorable changes in the trabecular bone. So decreased trabecular number, increased trabecular thickness, increased trabecular separation, and reduced trabecular bone volume over total bone volume. So that's all at the distal radius here. And at the distal tibia, we didn't see as significant of changes, but we saw a similar pattern here with the trabecular thickness and trabecular separation. So our results are quite different than both of these studies because we do see improvements in cortical bone, but we did similarly see that trabecular bone was reduced in our study. Then when we look at the those who are taking masculinizing hormone or testosterone, there was really no significant changes at the spine or the distal radius. You'll note here that I only had 4 participants in the study, but only 3 had lumbar spine data. So it gets kind of quite small. It's just enough to do, a paired t-test, but there's a lot of variability in the sample as well. And then when we look at the quantitative CT numbers, again, it's just 3 participants, but we see cortical thickness is increasing and cortical porosity is reduced, so kind of some favorable changes in the cortex, but we see that cortical volumetric bone density was reduced. So kind of conflicting results here at the distal radius. And then interestingly, at the distal tibia, the trabecular bone volume increased. So it's probably that this study is just so small. We only have 3 participants, but we did see some significant findings, which kind of have to think about in context of other published studies. So some possible reasons for the findings that we found were for transfeminine individuals, when we're starting gender-affirming hormones, estradiol is started kind of at a lower dose and it's titrated up slowly over time, but it takes some time for testosterone to be suppressed. So it could be that there's, the positive effects that estradiol has on cortical bone that we discussed kind of in the beginning of the presentation, but that the testosterone is being reduced and maybe not having that impact on the trabecular bone that we expect it to. And then in transmasculine individuals, it's quite easy to suppress endogenous estradiol with testosterone. And so maybe that's why we're seeing, kind of more net neutral changes in the bone, and that testosterone will be aromatized to estradiol, and that'll kind of preserve bone density, both cortical and trabecular. But that's kind of the summary of the results that we have so far. So to conclude, that estradiol is the dominant sex steroid in bone for all individuals, although testosterone does have an important impact, particularly on cancellous bone. Transfeminine people appear to have kind of poorer baseline bone health prior to gender-affirming hormone therapy, while transmasculine individuals appear to have similar baseline bone density as compared to cisgender women. Gender-affirming hormone therapy has either a neutral or positive effect on areal bone density in both transfeminine and transmasculine individuals. And then transgender and gender-diverse individuals with risk factors for osteoporosis or low bone mass for age, and history of gonadectomy, lower dose gender-affirming hormone therapy use, and or use of GnRH analogs during puberty should be screened sooner for osteoporosis, additionally to traditional risk factors that we are used to screening patients earlier for. And then the results so far about volumetric bone density have been quite varied between sites, but our results here suggest that there's definitely favorable cortical bone changes in transfeminine individuals, which is contrary to currently published literature. So with that, I'll leave you with my email here, and I am happy to answer any questions, and thanks for your attention.
Ty, can I ask a question?
Absolutely. I was just going to say great talk, and we'll open it up for questions. So Joe, go right ahead.
Yeah, Jen, that was terrific.
Thank
a
you.
lot of new information for me, so thank you. So just a comment about the importance of estrogen as the experiment of nature is the aromatase inhibitor. I said that wrong. The aromatase deficient males who have very low bone density in the absence of estrogen. But then a question. So as I recall, testosterone stimulates periosteal bone apposition. So is there any data on, say, radius width in cis males versus long-term trans females age matched?
Not to my knowledge.
Okay.
Not to my knowledge.
I mean, there are. It increases appositional growth way more before we stop growing, but it continues throughout life to increase appositional bone, and I don't think estrogen does that. So.
Yeah, that would certainly be interesting, but there's really not a wealth of literature in general, but particularly in the bone sphere, there's very few studies.
So I have other questions, but
Great.
why don't I let other people ask first, Ty?
Herschel's got his hand raised, so Herschel, you're on.
Yeah, Jen, great talk.
Thank
I
you.
might have missed this. I'm a little slow on the uptake today. No jokes, Joe. But is there a theory or theories why the transgender start out have a higher risk to start with? Are there any theories about that?
Yeah, I think it's probably multifactorial. Probably related a lot to the kind of minority stress model, um, high prevalence of vitamin D deficiency. But I think probably the big one is that there's lower kind of physical activity.
Yeah. So
I
the
think
reason
that's
why I
what,
brought it up is that
yep,
the minority stress issue is something I've been looking at. And there's now some good evidence that cortisol is higher too, which would have a negative effect on bone. Not in
right.
this population, in a different population. But I was wondering if anybody had ever measured the cortisol levels in these patients.
Yeah, I know there was quite a bit of talk about minority stress as it relates to cardiovascular risk at the recent WPATH meeting in September, and probably cortisol is maybe impacted in that sphere as well. But I don't know if I have like a specific study I can cite. I'll see if
Okay,
anyone's really done anything, if I can find it, but that certainly would make sense that that might play a role as well.
thanks, Jen.
Mhm.
Great. Other questions? Well, I have one kind of, I guess, straightforward question. In terms of earlier screening, in the groups that are at high risk, um, what does that really translate to? It seems, gender affirming hormone therapy is beneficial for bone density to different degrees in the different genders. But if individuals don't have those high risk features, should we be screening sooner as well, or just using standard screening? And I guess then the question falls on trans men. Do we lump them in with the screening that we do for men, which for most men is not very well done, we'll just say.
Right. Yeah, I know there's different recommendations out there. So I think the one that talks about using age 65 as a good marker for just routine screening is San Francisco. UCSF has some guidelines published. So they suggest 65, just kind of like the cisgender guidelines, but you might screen earlier, like around, I don't know, 50 if there's some of those risk factors present, or you might want to get a baseline bone density prior to someone who is planning on a gonadectomy, for example, or certainly if someone's going to be on GnRH analogs, like our pediatrician colleagues are probably getting baseline bone densities as well that should be followed longitudinally.
Great, thanks. Other questions?
Well, I have a comment,
Go.
Jen. So, I'm interested in this dilemma on the young people and what scores we use.
Mm-hmm.
So I think we're all used to using the ISCD guidelines that we use Z scores if they're males less than 50 or premenopausal women. But I learned this in preparing for a talk about premenopausal osteoporosis recently. I actually didn't know this. But an IOF working group disagrees with that. And they're saying, and I just had to pull up the slide. They're saying we should use the T score in
Mm-hmm.
young adults who stop growing. They disagree with
Mm,
the ISCD. Now, I have a problem with that because you stop growing long before you reach peak bone mass. But
right.
maybe a compromise would be we start to use T scores at younger ages,
Mm,
perhaps 30, when I think most people have reached peak bone mass before
right.
that. So, it is
Mm,
it's a complicated problem. That which gender Z score do you use? And if we were to switch more to some T score numbers, at least we have one database that we're comparing to.
Yeah, that would certainly make things less confusing, I think, for interpreting bone density and those between 30 and 50. It would simplify that process quite a bit. But
thank you.
Great talk, Jen. I just had a quick question about your study. Are you guys recruiting more individuals?
no, actually, that study was started by a fellow who graduated, and it was kind of a time limited study, so not recruiting more patients right now. So hopefully we can maybe work on getting it published, because there are some kind of interesting findings, but probably not with bigger numbers. Just going to be the numbers that we have.
And then I may have missed this, but the hormones were not controlled. So did any of the participants have gonadectomy?
No, no one had gonadectomy in our study. Yeah, because I think, we were still going by WPATH guidelines and insurance regulations that I think at the time then it was 2 years of gender affirming hormones before being kind of okay to get gonadectomy, or it was 1 year, I think, but some insurances were saying 2 years. So no one had gonadectomy in that study, and to our best knowledge and estimation, everyone kind of had expected bone density for, their age and sex assigned at birth when they joined.
Great. Yeah. Thank you.
Mm-hmm.
Great. Well, if we don't have any additional questions, I will say thanks, Jen. It was a great talk. Thank you for joining us. Any last minute questions, we'll take them. Otherwise, have a great rest of your evening, everybody.
Yeah.
Thank you very much.
Yeah. Thanks for your questions, everyone.
Great.
Thank you.
Thanks a lot.
Bye.
Take care.